Just want to say good morning to everybody and thank the organisers for inviting me. I'm going to start with a little bit of an apology in advance. I'm going to give my presentation and run, not because it's going to be so bad, I hope, or I'm afraid of you, but I'm a non-exec director at Heart of England Foundation Trust Board, and we have our 2 board away days. So I'm actually come here and then I've got to go back and do some extra work. So I apologise in advance, but hopefully, the organisers have my details and they are on the last slide. So I'm quite happy for anybody to contact me after this if they need any further information or want to make any critical comment. So, okay, thank you. When I was asked to do this presentation by Sarah Jane, I kind of had a bit of a thought about what am I going to talk about. And although I've never watched the programme, all my friends were obsessed with the programme Breaking Bad, which, if you remember, or from what I'm told, was about how somebody starts off, perhaps because of pressures in their own life, they start off not on the right track, but things escalate to a point where they get out of control and to a point where the consequences of decisions are no longer in their control. And that kind of reminded me a little bit about what's been happening in various parts within nursing and within healthcare. We've had a lot of challenges to the profession, and we've had even more challenges to the NHS and our provision of good quality care. We've had challenges to the training of nurses and students, and we've had challenges to what we as healthcare professionals do, what's our contribution, particularly around balancing the science of our profession, which is where a lot of us think about the research and evidence, and balancing that with the art of giving good care. So I actually thought that this conference today, which is about encouraging us to be involved with producing evidence to support our practice, is really about breaking the bad cycles, breaking bad habits, and breaking bad thoughts about where we sit in being producers of research as well as users. So my call today is about being champions and championing the science and the art of research to make us a better health force and a better profession altogether. Oops. Can't see here. Okay, that's better. So, what's nursing? What makes a nurse? Is it because we historically sit by the bedside, watching over those people during their worst times? Is it because we work in communities and we help particularly the elderly to stay as healthful as possible during their lives? Is it the way we educate children in health education and outside that so that they can take care of themselves in further years? Which of these things make us a nurse, and which of these things are the ground force of a good healthcare profession? Is it our care? Is it the art of being there at the time of greatest need? Is it the art and the privilege of being with people towards the end of their days? Or is it the quality of the education and our understanding of the evidence that underpins our practice? Which of these makes us a nurse, and which of these is most important for good quality care? So is nursing practice an art or a science? Which of these, where on the continuum are we? And that's really important because that determines whether we should be involved in research, what type of research we should be involved in, and really what's the point of it in the first place. I think what's missing before we look at this is some history. One of the greatest challenges to nursing, I think, is to remember the past. Often we're so much in a rush to push forward for the future that we forget the past. We forget the importance of understanding the context in which nursing arose and the context in which we are able to sit here today and even have this debate. Contrary to popular opinion, nursing did not begin in the nice, clean, sterile hospitals that we have today. It didn't begin with Florence Nightingale. It began long before that. It began in the squalor and the slums of Victorian England and beyond. It began because poor people could not afford to pay for medical attention. It began because people lived in situations where their life chances were dependent on almost a roll of a dice. In these situations, women went into homes where the doctors refused to go. At that time, they weren't community nurses, they were sanitary inspectors. They went into homes where children, if they survived childbirth, usually died before the age of 1. Overcrowding, living with people who died in the night because you had to wait for people to come around and collect the bodies was every day. In these situations, that's where nursing work began. The sanitary inspectors were the first people to actually collect evidence about the status of health of the poor and the status of health beyond the boundaries of the more richer estates. It's the first time that there was actually written evidence about how poor people's health was in the general public in the UK. That's where nursing work began. So when we talk about fitness to practice, it's good to think back then, okay, so what kind of nurses did we look for? Nowadays we have to have certain qualifications. There was a whole push towards recruiting students who are emotionally intelligent and a whole range of things. But back then, in that situation, what did nurses actually need? Let's look at the evidence. The Perth Sanitary Journal of 1904 identified these as the key characteristics for entry to nurse training. Nurses needed to be young, handsome, attractive, beautiful, pleasant, tidy, well-educated, and up-to-date. And for those of you who are not sure what that looks like, here is the ideal nurse. And the rationale for this was that it was felt that when people were sick and when people were at their worst ebb, they needed to have something or somebody nice to look at. That was all. So you can see how the context in which people did their nursing work, the slums and the squalor and actually the poor health and poor life situations, didn't really match with what was required. The idea was that as people had so much ugliness in their life, they needed something pleasant when they got ill. We've moved on from that, happily. If you think about the history of where nursing and healthcare professions have developed, we've developed to challenge a whole range of areas of health work. We've developed to challenge threats to health and well-being that come from sanitation. The sanitary laws of the past were one of the reasons why we are no longer allowed to throw bodies in the Thames. Sadly, the driver for that wasn't because everybody was dying, but it was because it was poisoning the water supply of the rich and better off. However, at least we stopped throwing the bodies in the Thames. So we've responded to sanitary challenges. We've responded to challenges around personal ill health. We've responded to challenges of changing environment, the impact of global warming and other environmental disasters, man-made or otherwise, on health. Nursing as a profession recognises the importance of responding to people's needs at time of work stress. We have lots of examples now about the impact of working environments on health. We respond to the changes in the way in which we produce our energy. Nurses are there working in industrial care, but also in dealing with the consequences of industrial disaster. And we have the modern threat now of the genome. We have challenges around germs and resistance of bacteria in treatments that we've previously relied on. In all these situations, over a period of time, nursing has responded and healthcare has responded to provide people who are fit to practice. And we've not done any of this just, as a fluke. All this has required, I would say, both the science and the art of the profession, and the evidence to underpin what is good practice, what is best practice, and what simply doesn't work. So for me, the guiding philosophy around the importance of the art and the science of our profession is this. It's important because in nursing, we've always responded to health issues, whether they're individual, group, or population level. And how we do that is a good reflection of our contribution, not only to the workforce, but also to the communities in which we live. So it's not just about having the evidence, but it's how we use the evidence. It's how we see ourselves as professionals and how we stand and defend the profession that historically has actually driven a lot of the changes that have happened for individual people and individual communities. So whether we respond to nursing as a science or an art or a combination of both is as much a driver of our future as it is of our communities. The Wanless report in 2004, I think, summed it up really well. I don't think I could sum it up better. And it describes how professional practice is the science and the art of promoting health, preventing disease, prolonging life through organised efforts of society, not by fluke, through private, public, communities and individuals. It takes all those things to produce the science and the art of a profession. And professional practice is about all those things. So when we move forward and think about, okay, is it science, is it art, and what kind of evidence do we need to help us perform our duties? I think there are 4 key principles that we need to think about. Health as a positive resource and a lifelong process. Our focus now in nursing care and in health care is on promoting health. Preventing illness is part of it, but it's more than just simply treatment of a condition. The reality is that most people live with their ill health for most of their lives. And most of that time they manage their health outside of a hospital, in their own homes, going along and trying to do their own everyday things. And the importance we have now of patients, the public and carers as informed and active partners in that. I, for one, as a member of Involve, are really pleased that at last, even when we apply for our research grants from the NIHR, we have to have patient-public involvement. For me, it's been a bit like the seatbelt law. You know, when it was voluntary, not everybody did it. And now they may complain, but they have to do it. And I think that's a good move. It's about an inter and intradisciplinary approach, and I think that's really, really important. I think nursing particularly, as a nurse I can say this myself, nursing is guilty as charged of spending too much time making divisions between the different types of practice. Almost to a degree, I would say, where you have to be measured as how good a nurse are you? What type of nursing do you do? And if you work in one area compared to the other area, you're not really a nurse. So I think interdisciplinary work is as important as working across with other professions as well. Sorry, intradisciplinary. And through these, what we get, what we are blessed with, is a sustained and accountable improvement in practice, in policy, in education and research. Evidence is not just about writing the paper. Evidence is what makes a difference. Evidence collected by the sanitary inspectors way back is the reason why we know that public health is important. It's the reason why we know that often people's ill health is not their fault. But without evidence, we would not know that. So moving forward, let's focus on the science. How do we then transform healthcare science? How do we contribute to the science part of our profession? In the 21st century, it means that what we need is more innovation. Let's go back. It means that what we need is more innovation in health, new products. We cannot use the same things over and over again forever. We need creative and enterprising practitioners, not just followers of the next rule because it's the rule that we had. It obviously doesn't like me. Here we go. We also need to have knowledge translation. And for those of you who don't know what that is, knowledge translation is about using what we have in one area and applying it to another. Translating that knowledge so that it's appropriate, so that it fits. It doesn't mean just cutting and pasting it and using it in the same way. So something that works in one clinical area doesn't automatically work in another without us doing anything about it. But that means research, evidence, accountability, evaluation, and then making the changes. And that's the science of our work. We have to appreciate the art. Fundamentally, we're in a caring profession. And appreciating the art of healthcare is actually appreciating that the science without a heart is cold and damaging. Maya Angelou, who unfortunately, as you know, died quite recently, said a very, very important thing that we must remember in the art of nursing. People forget what you said. They'll forget what you did, but they will never forget how you made them feel. If you look at the majority of the complaints that are made by patients and families about the care they receive, it's not about the nature of the drug. The majority is not about a mistake. The majority is about the way they were treated when they came into hospital or somebody came into their home to provide care. So it's important that any evidence, any science, remembers that the art of the profession is equally important. So I would say we need both science and art. And what do we get if we combine these contributions? We're able to then support healthy lifestyles directly by giving advice, and also indirectly by creating environments that are supportive to health, environments that enable people to take part, enable people to have control over their health and make informed choice. As soon as we say informed choice, it means that we need to have something to inform them with. We need some evidence. Informed choice does not come from my opinion. It comes from me giving you a range of options based on what we know to enable you to choose what's best for you. And that's about helping people to understand their health choices. And that's where the art comes in. The art in nursing is about being able to take in the information and translate it into a form that the person can understand so they can make a choice. And that comes through health promotion information. It comes through health improvement advice. And the key word there is advice. Not telling people what to do, but giving them the advice so they can make the choices. And it's also what we get if we combine science and art together. We're able then to develop appropriate skills using reliable and appropriate evidence. And that links to the knowledge translation that I talked about before. And fundamentally, in order to make any major change in healthcare, we have to be able to inform policies and inform leadership nationally and locally. Because there's no point us being really, really good at what we do in one little place where we work. If that's really that good, then I think we have a duty to share that, disseminate that out, so we can give other patients, other families, and other peers of our own an equal chance of benefiting from that experience. So Breaking Bad, what is it about? It's about championing the art and the science of healthcare. It's about leading by example. It's about professional currency and interprofessional credibility. Professional currency means that as individuals, we have the obligation to be best informed so we can give the best care. We have the obligation not to be afraid to actually learn something new. That means that we need to generate nursing evidence, nursing evidence based in the UK. Much of our nursing evidence comes from outside the UK. That's not to say that it's not relevant, but we need to use that and think, how does that apply here? In a different context, is it applicable? Does it work? That is the science of our inquiry, which we then apply in our care. And that brings to the next point. It means we use research in our professional practice. So we have some assurance that we are using best practice. It also means that we need to look sometimes beyond our own locality. We need to know locally, nationally, or internationally how what we're doing makes sense. Because even if we train as nurses or train as healthcare professionals and we stay in the same place, the wonderful migratory world we live in now means that the population changes around us. And I think the first challenge for us as healthcare providers or planners or managers or educators is to know our population. What we're teaching students, what we're training our workforce for, and the services we're providing must supply the community who are likely to walk through the door. If it bears no resemblance to our population, how informed are we about what actually is going on? And that means active engagement with local healthcare needs. Even in the 3.5 years I've lived in Birmingham, the population has shifted. The numbers haven't changed, but the profile has. And I wonder how many educators, care providers, and planners have actually adjusted what they teach, plan, or provide to account for that change. So, advancing our profession. As I'm in a university, I thought to talk a little bit about education. Contemporary education, should include creative, science, and education, innovation. We need all those things, because even if we work as educators now, we are training students for things that we will never have to face. As practitioners, we need to embrace the science and the art of our profession as a legitimate part of our role, wherever we practice it. And our systems and policies should make sure that the environments that allow science and art to flourish exist. So there's something there for all of us, educators, practitioners, and planners. Ask yourself, in your education system, in your practice areas, and in your service planning or your workforce planning, are you doing this? Because without these things, research, science, art, and evidence will struggle to survive. John of Salisbury talked about standing on the shoulders of giants, and what he talked about was the way in which we use the past, the way in which we use the vision of those who came before us to help us understand and make sense of what's happening now. And that brings me right back almost to where I began. If we don't know where we came from, we have very little idea of where we're going. And I quote in him, he said, "We are like dwarves sitting on the shoulders of giants. We see more and things that are more distant than they did. Not because our sight is superior or because we are taller than they, but because they raise us up, and by their great stature they add to ours." If we don't know the history of our areas of work, we're trying to look over a precipice from a lower point. We need to understand evidence and what went before so that we can make a decision as to whether it's appropriate moving forward and how we need to change it. As I wind up, a couple of things that I want to leave with you. I think, as I speak to the students in the room and the practitioners and the educators, what we need to apply science and art is people who have ability to take risks and use initiative. Risk and initiative are everyday words for science and art. Risk is taking a chance, trying something different, seeing if something works, questioning something. It's all risky. An initiative is doing something about it, and that takes an art. An art to make a decision, and an art to actually apply it. You see here two contrasting pictures. As we are at the anniversary of the First World War, you see these are contrasted pictures of nurses, showing risk and initiative in both senses. From the older picture of nurses who continue to nurse, wearing gas masks. The science says the mask will save you. The art says the patient still needs care. And similarly for the nurse here working out in Uganda. The science says this is the place of greatest need. The art says that people need care. There's no difference. And finally, I want to leave you with the words of Clara Barton. And these are all history lessons. If you've never heard of Clara Barton, that's somebody else you need to look up. Clara Barton was the nurse who founded the American Red Cross Association. She was challenged constantly about her wish to nurse not in a hospital, but on the battlefield. And she said, we should dare to be different. And that's what I think this is about. Research is about daring to be different. And she said, I have an almost complete disregard of precedent and a faith in the possibility of something better. It irritates me to be told how things have always been done. I defy the tyranny of the precedent. I go for anything new that might improve the past. I cannot afford the luxury of a closed mind. And that's what I'll say to you. Take the science and the art of the profession and dare to be different. Thank you.